Good morning. I'm Dr. Shira Dinner from Northwestern University in Chicago, and today I'll be presenting approaches to Philadelphia chromosome positive and pH-like acute lymphoblastic leukemia. So for the purpose of today's talk, we'll start by reviewing the clinical outcome of adult patients with Philadelphia chromosome positive and pH-like ALL and the diagnostic approaches to pH-like ALL. We'll also review the clinical trial data on tyrosine kinase inhibitor combination therapies for the treatment of pH-positive ALL and how we can extrapolate this to pH-like ALL. I'll then focus on the clinical data for blinatumomab and inotuzumab in pH-like ALL, and finally summarize the key efficacy and safety data of currently approved immunotherapies and the future directions for pH-positive and pH-like ALL. pH-like ALL, while it does not have the translocation 922 or the BCR-ABL mutation that we see in Philadelphia chromosome positive ALL, has a very similar gene expression profile to what we see in pH-positive ALL. It's characterized by mutations in tyrosine kinases and cytokine receptors, which results in mutations in CRLF2, EPO-R or JAK2, ABL class fusions, PDGFR, CSF1R, among others. And typically all of these are also associated with abnormalities in Ikaros as well. So in terms of the older adult population and the incidence of pH-like ALL, this is a little less well established. In the graph on the left, you can see the German leukemia group data looking at the incidence of pH-like ALL. And they show that it appeared to peak in the adolescent and young adult group at around 25 to 30%. However, then as patients get over the age of 40, it quickly drops off, and they reported it in only about 10 to 15% of patients. And there were similar findings by the Dutch and Belgian HOVON leukemia group. On the right-hand side of the screen is some of the data presented by the MD Anderson Cancer Center in the United States. And they showed that about 33% of patients have pH-like ALL. In particular, those over the age of 40 have an incidence of about 25%, whereas those under the age of 40, so fitting into the AYA subgroup, it's higher at about 42%. So that averages out to this 33% that we see here. And the vast majority of those cases were CRLF2 mutated in about 60% of the pH-like cases. And then MD Anderson also reported that about 30% of patients had pH-positive ALL. And once again, this was higher in the older adults over the age of 60. It was about a 50% incidence. Unfortunately, across the age groups, all the patients have poor outcomes for pH-like ALL. Children, AYA, and adult patients have a 5-year survival rate of approximately 20% for pH-like ALL. In the graph on the far right, you can see that if we look at the specific mutations that are occurring in pH-like ALL, the blue line is those who have a CRLF2 mutation, and they have the worst outcome of all, and their survival at 5 years is less than 20%. So how do we evaluate patients for pH-like ALL? I think it's important for us to know, since we know it has an adverse prognostic characteristic. Option A is something called a low density array gene expression profile. This has been developed predominantly by Cheryl Willman at the University of New Mexico, and it is a CLIA certified test. It's being used in several clinical trials by the Children's Oncology Group and currently in the Alliance A04-1501 adolescent and young adult study, but can also be used for standard of care testing by institutions that would like to send out this testing. Many institutions, because they do not do the LDA testing in-house, have developed testing for CRLF2 expression, given that this is the most common of the pH-like abnormalities. CRLF2 can be readily detected by either flow cytometry or by FISH, and then can be validated by the other modality. If a CRLF2 mutation is not identified, then typically FISH is used to check for an ABL, PDGFR beta, CSF1R, JAK2, or EPO-R mutation. And then in many instances, you can use RNA-seq, next generation sequencing, or focused mutation analysis to look for things like a JAK mutation, which tends to be present with the CRLF2 abnormalities. So in terms of talking about treatment, I wanted to focus first on Philadelphia chromosome positive B-cell ALL, which has been studied longer and more broadly. This was one of the first studies and one of the largest done by the UK and the ECOG cooperative group in the United States, number 2993, which looked at the addition of imatinib as a tyrosine kinase inhibitor to chemotherapy in Philadelphia chromosome positive B-cell ALL. The trial was started prior to the availability of imatinib for this disease subgroup, and then was amended to include imatinib at a later time point. And what you can see in the Kaplan-Meier curve at the top is that clearly those who received imatinib with chemotherapy had an improved overall survival of 32% compared to only 19% for those who did not receive imatinib and only had chemotherapy alone. They also looked at the timing of implementing imatinib in treatment. And for the patients who received early imatinib intervention during induction chemotherapy, rather than starting it at later time points in the chemo, they also had improved outcomes with a 39% survival for those patients. And overall, it was thought that the improvement in survival for the imatinib treated patients was due to the fact that they had higher rates of complete remission, stayed in remission longer, and this allowed them to get to an allogeneic stem cell transplant. So implying the transplant is still the source of the survival outcome. So this was further addressed by the SWOG 1805 study, which was led by Dr. Ravandi, and it looked at dasatinib plus hyper-CVAD followed by an allogeneic stem cell transplant for young and fit patients under the age of 50 years old. The trial was amended at some point to include patients under the age of 60. And what it showed was that it had quite good relapse-free and overall survival rates at 12 months, at approximately 70% and approaching 90% respectively. They also did a landmark analysis that looked at the 175 days after achieving a CR or CRI. And what they showed was that those patients who got a stem cell transplant did significantly better in terms of relapse-free and overall survival. So this seemed to establish that the standard of care in younger fit patients with Ph-positive ALL is to do a stem cell transplant. Now, I should note that in the pediatric literature, this has not been observed. There has not been shown to have a benefit of a stem cell transplant in the frontline setting for those who have TKI added to chemotherapy and achieve an MRD negative response. So we know that chemotherapy and tyrosine kinase inhibitors are the standard of care for Ph-positive ALL. The 5-year overall survival approaches 35 to 50% with the addition of first or second generation tyrosine kinase inhibitors to chemotherapy. Up to 75% of patients, however, that relapse will present with a T315I mutation. Ponatinib is a third generation pan-BCR-ABL tyrosine kinase inhibitor that has activity in patients with the T315I mutation. And there was a phase 2 single arm study that demonstrated high response rates and high rates of MRD negativity when combining ponatinib with hyper-CVAD, which I'll review next. And it begs the question, can a more potent TKI like ponatinib replace the need for an allogeneic stem cell transplant? So this was a single arm phase 2 study. It gave ponatinib 45 milligrams daily continuously during induction. The protocol was amended to limit this to 14 days. And after patients received induction, the ponatinib was reduced to 30 milligrams given continuously. If they achieved a complete molecular response at any time point, ponatinib was further reduced to 15 milligrams. After completing 8 courses of ponatinib and hyper-CVAD, patients then received maintenance with ponatinib for 2 years, and after that, continued ponatinib indefinitely. The response rates were quite impressive with this regimen. 100% of patients achieved a complete hematologic response, as well as a cytogenetic remission. Major molecular response was 94%, and a complete molecular response overall was seen in 86% of patients. And notably, by 3 months, which is approximately 3 cycles of treatment, 74% of patients had achieved a complete molecular response. As well, 95% of the patients did achieve an MRD negative response by flow cytometry, and Importantly, there were no early deaths due to toxicities of chemotherapy. Only 13% of patients relapsed. 3 of these were on ponatinib at the time of relapse, 6 were on other TKIs, 2 were not on any tyrosine kinase inhibitor therapy. But relapse actually seemed to occur somewhat late at 21 months. The median follow-up was 44 months, and they showed very impressive 5-year overall survival rate of 74% and an event-free survival rate of 68%, so quite significant. And importantly, only 22% of their patients went to a stem cell transplant in first remission. And interestingly, those who underwent a transplant had worse outcomes, with a 5-year survival rate of 66% compared to 83% in those who did not get a transplant. So this would actually suggest that transplant should not be considered in certain instances when patients are getting an intensive TKI like ponatinib in combination with chemotherapy and achieve an MRD negative response. Now, it should be noted that ponatinib does have a black box warning for cardiovascular events. In this study, they saw 11 venous thromboembolism events that resulted in no treatment-related deaths. 8 of the 11 events were receiving 45 milligrams of ponatinib at that time. There were 6 arterial cardiovascular events. There were 2 fatal treatment-related myocardial infarctions prior to study dose adjustment, which was implemented at patient 38. And there were 4 grade 2 or 3 angina events. So it is present that there are cardiovascular complications, but perhaps not as severe as was previously thought. And it should be weighed when talking to your patients in terms of the side effect profile of the tyrosine kinase inhibitor and what their comorbidities are when making a choice. So what do we do for patients who are less fit and who can't get through something like 8 cycles of intensive hyper-CVAD? There have been several studies that have looked at a tyrosine kinase inhibitor in combination with steroids. And one of the most recent ones was from the Italian leukemia group, which presented ponatinib and steroids for the treatment of patients who were unfit for intensive chemotherapy. They gave ponatinib 45 milligrams daily in 6-week cycles times 8 cycles. And a complete molecular response was detected in 11 of 24 or 46% of patients at 24 weeks. So I should note that this is significantly less than what was seen with ponatinib and hyper-CVAD, which was reporting approximately 75% CMR at 3 months. However, the overall survival for this study was 88% at 12 months, and 13 of the 26 severe adverse events were considered related to ponatinib. There was a death suspected to be related to ponatinib. And I should also note that this study used pretty high doses of ponatinib, 45 milligrams daily, and only reduced for toxicities. They did not dose reduce if a patient achieved a complete molecular response. So it seems to be something we can consider for less fit patients, but is likely not going to be a curative therapy. The subsequent study that the Italian leukemia group did was looking at the combination of tyrosine kinase inhibitors and blinatumomab to further reduce MRD and achieve a greater complete molecular response. So in this study, patients first received an induction with dasatinib and steroids up to day 30, and then they received dasatinib alone through day 84. Subsequently, they received cycles of blinatumomab in combination with dasatinib. They assessed them for the primary endpoint of complete molecular response at the end of the 2 cycles of blinatumomab and dasatinib, but patients could receive up to a maximum of 5 cycles of blinatumomab with dasatinib. The median age was 54 years old. There was a fairly equal distribution of men and women. Median white cell count was 13,000, and the vast majority of patients had a P190 BCR-ABL mutation. Notably, after 2 cycles of blinatumomab and dasatinib, which would be approximately 6 months into treatment, 42% of patients had achieved a complete molecular response. There were an additional 18% of patients who had a positive BCR-ABL, but the quantity was not quantifiable. And so they were reporting an overall molecular response rate of 60%. It did look like the complete molecular response rate increased with subsequent cycles of blinatumomab. However, the authors did note that the outcomes were worse for those who achieved a complete molecular response at a later time point. So still clearly, it seems as though we have a lower complete molecular response rate than was reported with hyper-CVAD and ponatinib. In terms of survival outcomes, the median follow-up was short at 14.3 months. The overall survival was reported as 95% and disease-free survival of approximately 90%. And they did show on the right-hand side in the graphs that those who had an Icaros mutation or an Icaros mutation in combination with PAX5 or CDKN2A had worse outcomes. So it may be there's also an even further subclassifiable group of pH positive ALL that has worse outcomes, and maybe these should be patients that we're focusing on more aggressive therapy for. So this begs the question, what should we be giving adults with pH positive ALL? And this is something that's currently being investigated in the ECOG ACRIN 9181 clinical trial. The study randomizes patients to receive a tyrosine kinase inhibitor in combination with hyper-CVAD versus a tyrosine kinase inhibitor in combination with blinatumomab. It assesses them for minimal residual disease after their initial induction. And the primary endpoint is the overall survival based on the different induction regimens. And I think this will be a very important study in terms of further guiding us in terms of what we should be giving our patients moving forward. So learning from pH positive ALL, can we treat pH like ALL with a TKI and chemotherapy? In some of the initial reports on pH like ALL, they did include case reports of tyrosine kinase inhibitors demonstrating efficacy in pH like ALL. This included using ruxolitinib for CRLF2, JAK2, and EPO-R mutations, and the use of imatinib or dasatinib for ABL, PDGFR, CSF1R mutations. And I've highlighted below a table of current ongoing trials that are using dasatinib or ruxolitinib in combination with chemotherapy for pH like ALL. The ones highlighted in red are the two COG studies, the Children's Oncology Group. What those studies are doing is during the initial induction course, they're working patients up for pH like ALL. And if they identify an ABL class mutation, they put them in a subsequent study that adds dasatinib to their chemotherapy. If they have a CRLF2 or JAK pathway mutation, they put them in a subsequent study that has ruxolitinib added to chemotherapy. MD Anderson is also looking at studies that include dasatinib or ruxolitinib added to hyper-CVAD for relapsed pH like ALL. And University of Chicago currently has a study that adds ruxolitinib to intensive pediatric inspired chemo, the CLGB 10403 regimen for pH like AYA ALL. And then what about using blinatumomab or inotuzumab, some of the new immunotherapies, specifically in the pH like patients? So the study on the left looked at mechanisms of resistance to blinatumomab, and they looked at some high-risk patient populations. There were only 16 patients with pH like CRLF2, but what they found was that, interestingly, 75% of these pH like patients responded to blinatumomab and suggests that it might be a good drug for treating these patients. Similarly, the MD Anderson Cancer Center did an analysis looking at inotuzumab in high-risk patients and saw that 58% of the patients had a response to inotuzumab with pH like ALL. However, I should note the median survival was still very short at only about 4 to 5 months. So it might be that adding some of these drugs earlier in treatment, rather than waiting for the relapsed refractory setting, could improve their outcomes. This is currently being done in clinical trials. The ECOG 1910 trial recently completed enrollment and added blinatumomab to an intensive chemotherapy regimen. Currently, the AO4-1501 adolescent and young adult trial is ongoing and adds inotuzumab to an AYA intensive pediatric inspired chemotherapy regimen. And both of these are doing analyses to look at the pH like ALL patients. We hope to see that perhaps frontline addition of immunotherapies can improve their outcomes. So in summary, the outcomes of pH positive B ALL have significantly improved with TKI-based therapies. Frontline approaches are currently divided between hyper-CVAD with a tyrosine kinase inhibitor, and in particular ponatinib in that instance, versus blinatumomab in combination with a TKI. Both regimens show excellent MRD negative complete responses and molecular complete response rates. But they have very different toxicity profiles. It's obviously difficult to get a patient through several cycles of intensive chemotherapy. The role of a stem cell transplant in MRD negative CR patient remains unclear and does need to be studied in further studies, particularly for those who have received intensive chemotherapy. It's not clear that they also need a transplant. TKI and hyper-CVAD is currently being investigated in the frontline setting compared to TKI and blinatumomab in the ECOG-ACRIN 9181 study, and I think that will be helpful in addressing some of these questions. PH-like adult ALL patients clearly have higher relapse rates and worse overall survival when they're treated with conventional multi-agent chemotherapy. PH-like mutations should be assessed in all patients at initial diagnosis and upon relapse. This can be done by flow cytometry or FISH for CRLF2. One can also do a low density array for gene expression. As well, NGS and RNA-seq can be used to look for specific mutations. It appears that blinatumomab and inotuzumab have potential to overcome chemotherapy resistance and are currently being moved into the frontline setting in combination with chemotherapy in the hope to improve outcomes for these patients. Similar to Ph-positive ALL, we really don't know what the role of allotransplant is in a first remission for Ph-like ALL patients. There have been mixed reports, some suggesting that it improves outcomes, others suggesting it does not make a difference and they continue to do poorly. So this also needs to be investigated further. And finally, targeted therapies such as ruxolitinib, dasatinib, other tyrosine kinase inhibitors are being investigated in the frontline setting in combination with chemotherapy for Ph-like ALL. So we hope between this and immunotherapies, we can improve upon outcomes for these patients. With that, I'm happy to take any questions.